Connecting.
check, hello, hello, check, mic check, hello. Hello, check. Hello, mic check. Hello, mic test. Hello. Hello, mic test. Hello. 1, 2, 3. Hello. Hello. Check, check, check. 1, 2, 3. Check. Hello. 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 Check, check. Hello. Check, check. 1, 2, 3. Hello. Hello. Check, check. Hello. Check, check. Hello. Check.
Classic. Classic orthopedic geologist. I was just finished my He said, and after the result, he said that everybody thinks Mars should be on Mars. So now they are doing all those valves and stuff. That's the fun. So all the transformers will do after that. And see what the result, what happens as a result. It's all gold lit. There's a gate there. You put 9.
Hello. Hello. Check. Mic check. 1, 2, 3. Hello.
And then this is Friday.
Sir, good evening, sir.
Even the self-selected.
Narasimha.
Same listen.
That week I was good.
Okay, sir.
Podium.
Hello, check. Hello, mic check. Hello.
అవును సార్
Hello.
అంతా ఓకే ఉంది సార్ మైక్ అవన్నీ
National selection.
బిల్టిన్ తీసుకుంటుంది కదా
ఒకసారి కట్ చేసుకోవాలి
ఇందులో పెట్టారు ఇందులో పెట్టారు
He was confused. He's actually a doctor of philosophy. He was struck. I said, no, it doesn't work. When you were in that situation of survival was
అది వస్తుంది బిల్టిన్ మైక్ వస్తుంది
without surgery. But now that you're 1%.
Hello, hello, hello. Check, check, check. Hello.
This is the presentation. This one. Yeah? Yeah, couldn't do it. Yeah, come on. It's not going to affect, no, that's your HDMI. This, gone, yeah?
Yeah.
Ah, perfect. Which one is it? One bit of it. Okay. This is not going to affect the valve. No, sir. This will link to that? No, sir. It's not going to affect the machines. Okay, thank you. He doesn't know the
So evening everybody. Evening everybody. So I'd like to invite all of you to our evening CME on chest wall deformities and how we manage them. So we have had a Pectus workshop the whole day based with a Pectus clinic early morning, where we had around 5 to 6 Pectus chest wall deformity patients whom we discussed. It was a very fruitful one-to-one interaction with a pioneer in this field, Dr. Shyam, and also Rajkamal, who has come as a national faculty all the way from Chennai. Now in the afternoon we had an intraoperative workshop where we operated one patient with Pectus Excavatum, and Dr. Shyam was operating, and he demonstrated well how we perform a Nuss procedure. Now, the basic aim of the evening CME here was just spread awareness amongst our own colleagues on the possibilities of Pectus correction. We know it's a very untapped area. Very few centers in the country are doing work on Pectus. So we are also planning to do Pectus cases and set up a Pectus clinic to take forward the program in a bigger way. We'll have talks by our chief consultant, visiting consultant, Dr. Shyam. Dr. Rajkamal will also be sharing his experience, predominantly in Pectus Carinatum and also on the vacuum belt therapy. We'll have our chief guest of the evening, our beloved director, Dr. Pawan Gorakandi, will be joining us in a while. We'll also have the inauguration of a Pectus clinic. I'd like to welcome all the delegates present over here, Dr. Shyam, Dr. Rajkamal, our unit head, Dr. Vijay Kumar, Dr. Pavan Gorakandi is going to be with us shortly. So I'll kick off the evening CME by inviting Professor Shyam to deliver his lecture. Please come over, sir.
when Bal called me about this place, and I didn't even think that this will happen in this scale, this printout and everything. It's amazing organization. What I thought was that you guys are all, most of them are cardiothoracic. So I'll tell you what evolving surgical techniques are coming up, all aspect of it, so that it's an overview on it. So this is a history. In 1594, there was a classic paper on chest wall deformity. There's a fancy image from Da Vinci, if you like Da Vinci. He's got one old man with a Pectus excavatum. But that's just his interpretation of it. But actual operation was done by Ravich, and he presented it, and it still holds good. What he did at that time was a different ways, how he held it up, but we still modified what he started in 1947. And then came Professor Donald Nuss. He was a surgeon at King's Daughters Hospital in US, and he was doing a lot of Ravich procedure, and here are all young children. So he worked with one of the instrument person and designed these dissectors and bars. And he used to do without a videoscope, just by feeling. Very brave man. I don't think anybody should ever attempt that, because if something happens, you should be charged for manslaughter. But he got away with it. So I think Pectus deformity, usually I classify into these groups, because excavatum is funnel chest, carinatum is pigeon chest. Arcuatum is, I treat it separately, because when you start your Pectus practice, you will see now and again patient which you label it as excavatum, do correction, even after correction they look same. That's the arcuatum. That means manubrium in the body has an arc of a junction, and that has a totally different operation. Could be a modified small semi-Ravich, but that's a different operation. I classified into one which you do skeletal correction, because talking about surgery, and then we go on other things. Ravich, Nuss, we do some modified single incision, because we get a lot of patients who are doing a modeling career, and they want one scar, or some people are scar has issues, then we do that. Very small group of patients you can do that. This magnetic mini mover, it failed. They did trial. It looks amazing on the paper, but technically very limited. Pectus Up is a new technology I worked with. We do few cases, almost once to a couple of cases in a month, and we do it in between England and Dublin and Poland. The camouflage, which is a good thing. If patient has a cosmetic issues and fear with the pain, then do the camouflage thing. People used to do fillers, implants, fat injections, but they were crap, because if you put implants, they used to migrate and look like an alien on their abdomen. But 3D Anatomica implant is fantastic. It stays in a place and is a permanent implant. Other non-surgicals, there was some magnetic thing which is not there. The braces and vacuum bell. Braces of a carinatum, vacuum bell is for excavatum. This is how in a short Nuss what we did today. They didn't put a telescope there, but you imagine it's on the right side, and this is how we did it, and this is how we flipped it. This is a line diagram for Nuss procedure. Always use a telescope on the right side, and if you really want to experiment, put your telescope on the left side and see what you can see. Probably nothing, because heart comes in your way. And that's why, unless you got a dextrocardia, do it this way, even if it's redo. Only thing is, if you're worried, you can put your finger through the incision which you're going to put and feel the tip of a dissector, and you can railroad it. This is the cranes. These are elevation of sternum, like how Dr. Vishnu does. This is his previous teacher's devices. One of the best of all the crane. This is the best one. You get little iron curtain screws, put it on sternum, and elevates. Gets a good elevation. The trick is, if you do it, do whole procedure with crane up. After the you take it out, and you will see a better results with it. With less hassle, no sweating. Then there are different carinatum surgeries. Ravich, yes, but there are two guys. There's Yüksel Mustafa in Turkey, used to do these bars from outside, pressing it on. Like you put a Nuss bar inside, with this thing. And Dr. Vishnu will tell there is a sandwich technique. You put one bar inside, one bar outside. They look amazing on table, but the outer bar is visible through the skin. And that's my issue with it. And then carinatum braces have changed. In my practice, almost 90% carinatum, we put braces. Very, very rarely we do this thing. We are almost getting de-skilled doing that because under 18, braces are eliminated surgical need for them. This is the Ravich. You guys all know. You can put a midline on submammary for ladies where you have to elevate a pectoralis flap, and then from second rib to downwards, you take out the costal cartilages by sort of leaving the perichondrium back. And then after you do that, you may require some osteotomies on sternum to level it out. Either you use those rib fixing plates or Marlex mesh stitch behind it, or you can wire it, whichever, and then you can put a bar in these cases. This is Abrahamson or Yüksel's procedure. These are the bars. The stabilizers are fixed to the ribs, and the bars are on the outside. See, outside you look good results, but then see here, you can see the outside. There, see, you can see the bar outside. So that's an issue with it, but still, if people don't like scars, this is a good one. And these are the braces. I use TJO because it's very simple, less hassle, and it works. I've been using it for quite some time, and I only had 2 failures. One, because the patient kept it on a shelf and never wore it, didn't work. Second one, was a young girl, put a braces, and she got pregnant. The breast comes in a way, so that those are 2 people it didn't work, but everyone else worked. These are some cases. You may see these in the clinic, like that, and see before and after. You can see before and after, before and after. So very good results. I think within 3 months you see the changes, and then you use it up to 6 to 9 months and gets better. But if the children are younger, use the braces in the night time till they can wear it, because sometimes you get little pop-up of this one. But there are several braces. We are designing one which will be very, very reasonably priced for Indian population. We have one prototype. We have one patient. We can use it free of charge. Then after that, we can, if you have a orthotic department, we can design it. It's not that difficult, but there are some guidelines and things to do it. Only thing you can't use it, if the skin breaks, you can't use it. You do a compression test. You put it on the back, put your waist or a hand, and then ask permission from parents, okay? Their precious child is there. You press it like that, it looks very scary. And ask the child. And press it, if it goes in, the braces should work. If it doesn't go in, doesn't. Like this morning, we saw this young girl, how tough it was to reduce. The other chap, we could reduce it. So that's how you do the reduction test. This is a University of San Francisco, legendary institute. They made this crap, doesn't work. Even they claim in publication it doesn't work. It looks amazing idea, put something underneath and you get this funny shaped magnet on top and you're supposed to elevate this thing. Looks fantastic. But they had one success, that's it. I don't know what it was. But they have a publication and they're very honest in the results. On top it looks nice, but in the bottom of summary they have accepted that it's equivocal, that means they failed. So see, this is a conclusion. So I think we should give up. This is a fantastic, if you got a scary patient who's older, he doesn't want skeletal operation, pain is a factor for him, and doesn't even like Ravich, this is a fantastic. You take a CT scan, take the images, send it to France, Paris, they design it for you. What you see here, this is the template. It comes, you mark that template, and then you put a implant inside, and then close it. It's subpectoral. It's amazing. Why it stays there? Because the bottom of it, you split it and put it on the rectus division. That's why it doesn't migrate. And then you see results like that. It's a very good design, good this thing. This is vacuum band. You saw it in the morning. It's an amazing device, and technically it's a good one if patients are scared and they don't want surgery. Of course, no parents want any cutting on their children. So try this. There's a 50% success if you do from around 8-10 years of age. After 16, rarely works. After 18, it's homeopathic, as we say. But I don't want to upset the director there. But it's just the word. There is no remedy homeopathic on this one. So I think that it's a good one. If it works, I've seen good results. My own GP, his son, we fix it, and now he gives me VIP treatment now that his son is cured. So that's fantastic. So I think Pectus arcuatum is a skeletal correction. It's the best, but if patient is afraid, then you do camouflage with anatomical 3D modeling. I'll show you some images. This is how the camouflage. The results don't look that great, isn't it? This one looks good here, but that doesn't look that good before and after. But you can do this if people, because it doesn't affect anatomically inside. This is my other patient. Now, bless her soul, she's got married in February, and she was one of the colleagues, and she wanted to wear those gagra stuff and things for her wedding, and because of arcuatum, she couldn't. So that's the only reason she went through this really painful major operation. But we gave her a tiny scar, we went very lower down for the thing. So, and then we use this is the osteotomy. We call it the reverse osteotomy because we do it this way so that when it comes up. So not this way, so it should be like this. And you take a redo saws, those tiny ones, and go around, and then you put this was the edge plate for sternal lock, which is very good. But any plates, you can put two rib plates also. If you don't have any of this, just use 3 sternal wires, and they should fix the same way. That's a cheap man's repair bracing. See, look how that has, and now how the dress came just here, so she was very happy. This is the video I'll show you, single incision one. This chap was very famous model, and he usually used to do it with a dress, but then he wanted to do one shot from this end, and he had a tiny scar, a spot on left side. He went for a shoot in Australia, and then the COVID came after the operation. He stuck there for 2 years. Now, then he came back and we removed his bar afterwards 3 years. So that's how you saw today dissector. I'm telling you, there's a telescope here, okay? That's me, and that's my assistant. Go across. There is a one more trick I didn't show you. You have to clear up the skin before. You know, like how you do Abramson operation, you scrape and doesn't it? You have to do that. See, we put a tiny thread there, so we have a little small incision where one single stitch, but you have a big stitch, and you put a stabilizer on this area. We've done a bit rapid filming. I just want to make it into under 3 minutes. We do it in very selective cases because you have very limited control on it. When you're not passed out a dissector full through, sometimes the interspace is narrow. So you just have to play along You got to be wary of this. If you keep doing it, sometime you will damage the memory. He's now mitral surgeon in Liverpool. Very, very Arabic guy. See, you have to pull up. This is the most important trick. If you don't do that, your skin will get trapped. And then you put a stabilizers on that. It's a gimmicky, but you can make a name on it. Select symmetrical lower third pectus excavatum, 3.5, 3.3 is 4, like that. Young person with no fat. This wire thing will go around the ratchet to lock the stabilizer. In reality, you just need one stabilizer. Other people don't put stabilizer, then you have to fix both sides with a fiber wire or a wire. This is the de-earring. We have near 1,000 cases. Only twice I had to put a chest drain. This is how it looks. See the stabilizer on the other side. This is a Pectus Up, new technology. I think you guys will love it. It's a bit pricey, but if you can afford it, it's great. Initially when it came, we didn't have the sternal or this plate, and those were very difficult. When I showed this in some other hospitals, I showed them someone pushing this up. You know the belly, when he puts the foot on it, and then the thing's doing like that, so that's what's like belly. And then you see the Govardhan Pavat, when it lifts up, that's the other one. So it is, we have modified several things on it. The new generation is far superior and better and quick. I'll tell you what the modifications we did. So this came in around 2015. It's a Spanish surgeon who designed it. It's his company. And then the first one didn't work well. I made more money with this thing on removing them rather than inserting. Because it takes 5 minutes. You need an Allen key and it comes out. The new generations are fantastic because we help them to design. So they're so solid. You need a proper thoracic surgeon to remove it. So by last 2 years we have been doing this new model. It's fantastic. It's good. It only works on lower third, okay? It costs around £4,000 for the device itself, so that's pricey. But it's a very good titanium thing. I'll show you the video, which is, this is how the outer plate or rib plate